There we go.
All right, then fasten your seatbelts. Nabia, can you please confirm to me that you can see the slide on the screen?
Yes,
All right.
Yes,
I see
yes.
the slide. Yes.
All right. I think we are on the hour. A very warm welcome to each one of you. Good evening. So much for being here with us. And I'm going to request my colleague Nabia to check in if the streaming is working well. So if you can just have a look at that. And
We are live on Facebook and YouTube.
thank you. Thank you. And am I audible? Because it looks like some people are unable to hear me.
Bhavna, you're breaking a bit once in a while. I can hear you,
Hmm.
but a little bit of
Is this better?
yes.
Okay. All right. Glad, Sanjeev, that you are here. Once again, very warm welcome and delighted to invite you, welcome you to our 20th webinar. I cannot believe it. I can still remember the day we decided to have our webinars, and I felt so nervous, and not that I don't feel nervous today. I continue to feel nervous, but I feel quite amused and amazed that this is our 20th webinar. And the webinar is in the series of our programs called Compassionate Caring, the why and how of end of life conversations for the family. This is about understanding caregivers and their psychological well-being. As you will see that we speak about the overall well-being of caregivers in a certain framework. I would like to start this webinar by giving you a brief outline about who Caregiver Sathi is. An introduction to our organization would be are creating an ecosystem of well-being and healing for the primary caregiver. Now, family caregivers of those navigating terminal illness, chronic, or any other limiting conditions. Frankly, you could even add aging to this set of conditions. They have their unique challenges, and we support them through their caregiving journeys and beyond. We will create an environment of well-being by empowering the caregiver. So, our understanding of empowering or feeling empowered is if the caregiver has choice and access to what they wish to do, as well as an opportunity to be able to exercise that choice, then they are likely to feel empowered. So, we wish to help caregivers and their care receivers lead full lives. How do we do this? So, in today's world where we are right now in a virtual setup, having a technology enabled system has become absolutely critical. However, we do not want to lose the power of human connection, empathy, and compassion. So, we do awareness programs or education programs that are both online and offline. We have helpline, healing circles, which are support groups or groups in which caregivers can lean in on each other. We have communication through social media in order to build the awareness and create the understanding and this need for an absolutely new category of caregivers, provide access to relevant, reliable information that is available conveniently. And finally, we are in the process, which is of course a journey, of providing a tech-enabled support system, both through an app as well as a platform. Resources that we have built so far, and we are hoping to be able to bring them to the people who need them. These might be the tech-enabled support, which is the platform, the app, the website, the education programs, which are both online and offline, the app that is available to caregivers, a community that is available for caregivers to lean in on each other, as well as be able to support others. um, we do believe that sharing stories is a very powerful way for people to be able to change the narrative around caregivers and caregiving. We do have a culture and a strong social narrative where caregivers and caregivers are expected to sacrifice themselves, or caregiving is a duty and a responsibility. So much so that over a period of time, caregivers have actually become invisible to the common eye. We believe that if we can bring the stories of caregivers, who are actually gentle warriors in our current times, if we can bring their stories, their struggles, then we will be able to change the narrative around how caring can be done. Compassionate caring is another element in that. We have experts who have seen many caregivers and many caregiving stories and believe very strongly that compassionate caring means that it is caring for the patient as much as it is caring for the caregiver. So, how can family caregivers create a balance in the entire system so that they can sustainably provide long term care for conditions that are actually incurable? So, compassionate caring is about learning about caregiving in a way that caregivers are not compromised. We also have one on one caregiver coaching, family counseling, and a volunteer based respite program. How can you participate? Well, the healing circles and the support groups are for caregivers. I personally believe that we are all caregivers. We might not be caregivers today. We may have either finished our caregiving journey, or we might be potential caregivers, or we might be long distance caregivers. And we could certainly lend a listening ear and a helping hand. So the healing circles are not just for active caregivers, but for people who are also related to caregivers and well wishers. So you could join them and encourage the caregivers that you know to join them. You could bring your caregiving stories or the stories of those that you know, and we would be delighted to publish them in the article, video, or our podcast formats. Help us spread the word. The caregiver angle seems to be one that is not so popular or not so well understood as of now. So we need your support to spread the word and the understanding both in person and on social media. Um, Also, volunteer with us. Be an ambassador of our organization by helping us make connections with partners, hospitals, and organizations. We are a donation-based organization, so funds and fundraising is an ongoing challenge. We also offer internships to young adults who may want to understand the organizational working or communication, changing social narratives, or being able to work with caregivers from a psychological or social standpoint. So if you're interested in an internship with our organization, do apply in, and we will have a rigorous selection process. and you could be one of the interns with the organization. The framework of well-being and resilience that we would like to work with is that as a whole, well-being is a composite of both care and cure. And at the core is the psychological, spiritual, and physiological well-being. This is the core of an individual. And as an interface with the outside world, there are elements. These 7 elements include social, financial, legal well-being, life and work purpose, and all of this is encompassed in an individual's unique expression of existence, expressed through creative expression. These 7 elements constitute what we think is overall well-being of an individual. And when there is an imbalance in these elements, there could be stress. Unaddressed chronic stress leads to mental health issues, and what you and I, especially caregivers, can do is build resilient practices of mind, body, and soul. With that, it is my absolute delight to introduce you to the speaker today, who I have been so keen to invite for such a long time, but we have committed to do these webinars only once every other Friday, so it took some time. And we have with us Dr. Rajkumar Mani, and Dr. Raj is MD, FRCP London, USA, is a well-known name in critical care, pulmonology, and sleep medicine. I might need to consult you separately, Dr. Raj, on that. He's currently Director and COVID-19 management at the Yashoda Specialty Hospital in Ghaziabad, UP. In a career spanning nearly 40 years, he has made a mark in his role as a pioneer clinician, academician, researcher, teacher, campaigner for humanizing medicine and medical administration. He has been instrumental in setting up and leading cutting-edge pulmonary and critical care departments in several frontline hospitals across Delhi NCR, to fulfill a cherished dream of reaching out to the country's interiors. He developed tertiary care services in Mathura and Agra as the CEO of Nayati Healthcare. Dr. Mani has been deeply involved in the study and promotion of bioethics in Indian medicine. He published as the lead author the seminal guidelines by the ISCCM for end-of-life care. He has worked with the Indian Council for Medical Research to develop 2 key papers. One, the definition of terms used in end-of-life care, and a policy and standard operating procedures for the Do Not Attempt Resuscitation Order, or DNAR. Dr. Mani has published more than 100 papers in leading national and international journals. He was the editor-in-chief of the reputed Indian Journal of Critical Care Medicine, and he presently the section editor for Elsevier in developing prestigious online resource called Clinical Key. I am sure there's much more to his credentials, and this one page probably doesn't do justice, and maybe we will get a peek into that in our conversation. The second panelist today is Dr. Nagesh Simha, who is a surgeon and who's been involved in palliative care for over 25 years. He's one of the founders and the medical director of Karunashray, a 73-bed cancer hospice in Bangalore. He has an MSc degree in palliative medicine from Cardiff University. He was elected as Fellow of Royal College of Physicians of London. He has been a member of many task forces of Government of Karnataka and India, and is also the honorary tutor at the School of Medicine, Cardiff, and an adjunct faculty of Department of Palliative Medicine and Supportive Care at Kasturba Medical College, Manipal. What I know about Dr. Nagesh Simha is that he's quite a fighter and despite multiple medical challenges personally, is quite a live wire and full of energy, not just for himself, but for many of us. So I'm delighted to have the two of you here today, along with Naina, who has completed her BE in civil engineering. Oh, what a lovely career. From National Institute of Engineering under VTU in 2009, and from 2015 was worked as a planning and billing engineer at L&T Construction. Who would have thought that she would be in a panel like this? But 2017, she completed a MSc in counseling psychology from Christ University. She was a full-time caregiver to her bedridden mother for 2.5 years. In 2020, she joined Karunashray as a counselor and continues to work there. She's done a qualitative study on the topic of sex reassignment surgery in transgender transition into authentic self as a part of her research project dissertation for her master's degree. Naina, I am going to look forward to have a conversation with you about your dissertation in another forum. And along with her team, she conducted a mock qualitative study on the topic of inclusion of transgender community with respect to education and employment, and also developed a module on stress management and presented it at Sangma NGO for LGBT community. What an incredible panel to have today. And I will just take a little while before I invite each of them to say hello, to give you the admin announcements that we will spend approximately the next 60 minutes having a discussion regarding today's topic and its implications for compassionate caring. Broadly, there are 3 parts of this session, which is a conversation initially during which participants will listen and share their thoughts and questions in the chat box. We will incorporate the questions as far as possible during the discussion. There is a question answer session. Participants can ask questions by raising your hand or asking questions in the chat box, and we will incorporate them. We will request you to complete a form in terms of feedback and suggestions toward the end before leaving. And with that, we are now going to have a conversation. Hello, Dr. Raj.
Hello.
Welcome. Welcome, Dr. Nagesh.
Thank you. Hi.
And welcome, Naina. Hi, Naina. Can you just do a check on your audio? And while you bring that on, I would like to start by asking Dr. Raj to open the session with your opening remarks about the topic of discussion today, and then move to Dr. Nagesh.
So on the issue of end-of-life care?
On the topic for our
Right.
conversation today, yes. What are your opening remarks as we start this webinar today?
Opening remarks, okay. Opening remarks are, you see, without compassion, there's no medicine. There is no caring, of course. Medicine care is all about human contact. And compassion is the means of bringing human beings together in a care relationship. A neglected area is the caregiver, the primary caregiver. I think the whole focus is on the patient, and the physician community focuses on the patient and on themselves, but not on the primary caregiver. So I think it's a very laudable initiative to look at the one big resource, one big dimension of caring. Caring is a teamwork. So I think care of the primary caregiver is your focus, and it's a very laudable one, and I wish you great success, Bhavna and team.
Thank you so much. We will be talking about a fairly tricky topic. And Dr. Nagesh, what are your thoughts about this webinar and the need for conversations about end of life care?
I think it is an extremely important subject. First of all, culturally, talking about death is considered as inauspicious. In fact, uh, if one were to talk about death, it's almost as if you're inviting death to come to your doorsteps.
That's right.
And that, I think, is a cultural issue. And that is something that I think those of us who are working in this space need to do all that we can to demystify this. So I think that is extremely important. The second thing that has been proved, not only from anecdotal experience, but also by research. In fact, I was involved in a small study looking at spiritual concerns of Hindu patients admitted to my hospice as a part of my MSc, that was my thesis, is that some of these things which we feel that when we discuss it with patients or with our loved ones, that it would distress them. On the contrary, they would like to discuss that, but for some reason there is a little bit of a hesitation. And if we are able to encourage them and give them a safe space, and you get the conversation started, you will be amazed at how many things that come out of it. Of course, if one has to begin this conversation with a loved one, it requires a certain amount of experience and a little bit of guidance from people who have worked in this field. But I think that it is very, very important. Otherwise, we will be trying to do things which the patient may not want us to do, or not paying attention to things which they feel very important, although we as caregivers may not feel it's so important. So I think it's an awesomely important subject.
Thank you for that. It also reminds me about, my experience, my personal experience, and I spoke about that briefly before this webinar, which is that, when my father was navigating his terminal illness, and, he did pick up the conversation with me, and he did say that, you're traveling and, you might, the next time you come, I might not be around. And yeah, it always overwhelms me. I've said this so many times, it just
I
gets
know.
better of me every single time. And when I look back, that scene plays out in my head, how I was standing, where he was standing. And I was a mix of so many emotions in that moment. It was perhaps a bad timing as well. But there are so many days I look back and I wonder, why did I not create the space for him to tell me what he wanted to tell me? And what would he have wanted to tell me? I wish I can hear that. But unfortunately, we didn't have the resources at that time. We didn't have the guidance. And he was considerate for me. So I also think that sometimes the person who is unwell doesn't want to cause more pain to the caregiver. So if a conversation about dying is going to be painful, they also step back and they hold themselves back. And I so wish there was somebody who could have held both our hands and, guided, like you said, and taken us through that process. Um, I may not be living in a world of mystery and regret today.
That
So,
is true. That is true.
Is it audible?
Yes,
Yeah,
you
yeah.
are.
Yes,
You
thank you.
are. Thank you. And this is a good time. So, which is why we believe that, increasingly as, we are distributed, smaller families, this wisdom that may have existed in the elderly is not easily available to us. So with that, what are your opening remarks, Naina?
Actually, I am feeling that if I knew about this organization when I was a caregiver, it would have been a great deal of help for me, because I felt so lonely, sometimes so helpless in the situation, and I didn't know where to look for. And yeah, this is a very good initiative. Most of the people need this. even not only if they are caregivers of a ill patient or so, but we never know when we will switch places and will become a caregiver someday.
That's
Thank
right.
you.
No, that's absolutely right. I sometimes also feel that, your ability to live a freer life goes up if you can talk about death.
Yeah, true.
Um, why is communication, Naina, would you like to tell, why is communication important in end of life care?
See, it's about dignified living and also dignified death.
Mhm.
And people say that how people die remains in the memory of those who live on.
Yes.
So, when you have conversations like this, you'll definitely come closer to the people. But not only that, but also study shows that meaningful conversations like these lead to reduced guilt and depression in the survivors. And also, it makes the grieving process easier for them. One more thing is, see, when you're having a conversation beforehand, before the crisis, not in the middle of it, you'll be able to make a decision which is less stressful and less fearful than making it during the crisis. And there are so many emotional and moral distress the caregivers go through. It starts with a simple confusion of who is going to do what or what is really actually happening. From there, and the unpreparedness of the caregivers, the unpreparedness of the patient itself, which will cause more distress to both the members, both the parties, and the emotional overwhelmness in the face of vulnerability. See, every time we are all mortal, but we won't think about it. We will feel so vulnerable when the reality hits so bad that facing that will become emotionally challenging, emotionally overwhelming to both the caregivers and the patient. And the patient, when they go through a series of changes in their health and the treatment plans, which is constantly trying to provide a better care for them, but it's still constantly changing, they feel they have mood swings. Their emotions are so inconsistent, but the family couldn't really get it and they feel disconnected at that point. And that will also cause a lot of distress and emotional instability at times. And also the challenges of identifying and handling psychological pain. It's not only physical when it comes to patient care, both for caregivers and the patients. The psychological pain is so large that identifying it and handling it becomes very difficult if you are not prepared for that. So having the conversation beforehand, before everything goes down, and if you're not prepared, then how to handle it midst of the crisis is becomes very important.
So I know that it becomes very important, and I'm going to ask for some examples from Dr. Mani about this, which is so, when I talk about, let's have a conversation. Even when I was sharing about this webinar with my, let's say, classmates, my friends, they were like, "You're so morbid. You're talking about end of life. Why are you so intense and dense all the time?" How can, what can we do to make this not a difficult conversation that many people will want to say, okay, let's deal with this monster?
You see, as an intensivist, I by and large start conversations in the crisis situation, what Naina was talking about. But as a pulmonologist, I do have an opportunity to talk about it in the non crisis situation in the outpatients department.
Yes.
But I'll talk about the ICU first.
Okay.
What happens? I'll give you an example, a story. Okay, story you can always connect with. So there was this lady, let's call her JG. She was mother of a celebrity singer. classical singer. I can't go beyond that to breach confidentiality. So she had her big family, her sister, for instance, and then secondary relatives. So the mother was 80 years old and she had pancreatic cancer, which was extensive. So she came in with breathing problem, breathlessness, admitted to the ICU. So you have an opportunity in this setting to start a conversation very early. So what we learned over time is you don't postpone a difficult conversation. In fact, you directly plunge build a rapport, building a relationship, and building a, facing the context together, as the story unfolds is very important. And then once the initial ice is broken, then it gets easier and easier actually. So I actually started the conversation with the patient. And the patient is conscious, patient is in, well with it and ready for a conversation. You don't necessarily push yourself unless the patient is ready. You break the ice very gently. Patient has said, nothing doing, doctor. I don't want any intervention. I have made up my mind. I've watched myself. So I want an easy end. I don't want. So that made it very easy. Then I spoke to the family. The family, very often there are conflicts, but this time it was smooth. The family also had the same sort of opinion that what they will focus on, central to everything, is the mother's comfort and dignity. So we eschewed any escalation of a curative oriented treatment. Okay, no more than a non-invasive ventilation, not on a ventilator, okay, not for any organ support, not for any big medicines. Having done that, then we would have daily conversation. So this is one of the easier ones I told you about. So daily conversations were not necessarily easy because they had a lot of questions. Now, will she suffer? Are we taking the right decision? Are we denying her treatment? Are we doing something awful? Sometimes they ask, are we doing something illegal? But primarily, people don't talk about law. People talk about suffering. So our focus should be suffering, not economics, not law. When I come out of the ICU, when we are into this EOLC conversation with our colleagues, we all talk law. But with patients, we talk suffering. That is the reality. The actual clear present reality is suffering. So we would talk about how to mitigate her suffering. One of the biggest suffering is loneliness. We can more easily control pain, anxiety, delirium, okay. Even breathing. More difficult is a loneliness, feeling cut off and feeling helpless. Then the family support, the caregiver, the primary caregiver should be present. It's good for both of them. It's good for the patient, good for the family because they're also suffering. The suffering penumbra includes the whole family. So we allowed free visitation. See, this was a time when it was all very rigid and in ICUs. Okay, just half an hour meeting time, and as soon as they come in, they are asked to go, right? It's theirs. But we must understand, family is an intruder. They are part of the treating team of a patient in this situation. So towards the end of life, you make it easier by having a free access to the patient, and there is sometimes you give them a relatively sort of private area, or if it is even possible, move them out of the ICU to a private room. So we had a private area in the ICU where the family could gather, sit with the patient, chat about many things. So we completely changed the focus. We stopped doing tests, we stopped doing labs, we removed monitors and the sounds. Conversation was mostly centered around how to make her comfortable. Conversation centered around what I can do for you, the caregiver, the family. You know, I said I'm a doctor for you as well. I'm not just doctor for the patient. So this is one of the memorable family doctor relationships I can give an example of. So the most rewarding was a beautiful letter from the celebrity who I had admired since my youth. So that was a letter I preserved in a beautiful hand and lovely. So you see, we can give hope in the sense that we can provide meaning to the dying experience for both the patient and the family caregiver and the doctor caregiver. We are also caregivers. It gave such a sense of purpose to everything. You felt good being a caregiver. So I have given you an example. We can proceed.
What an endearing story, and what an example to keep in mind. There are a couple of thoughts that came to my mind as you were telling me this. The first being that, when my great grandmother was to pass away and I was a young person in the home, it was a very clear choice that, there will be no intervention. So, and it felt okay. Here's a person who has lived a full life or what seems like a significantly long life, and therefore you could make some of these choices for them in the sense of saying she wants it and it's dignified and let's make a transition. I think it is a little harder when the person is much younger and as the age reduces, that there is some kind of a relationship with hope, not giving up, etc. And with that, I will ask Dr. Nagesh to tell me and to tell all of us about the interplay and the of younger patients and end of life conversations when it feels more tragic or it feels not yet time.
What you said, Bhavna, is very correct. That philosophically, as one grows older, we feel that all right, I've had my life, everything is settled, whatever it is. But you'll be surprised, when I remember I have a cousin who is about 15 years older than I, and when we were kids, he was 30 years old. I said, "Oh wow, he's 30 years old." Okay, but as you sort of grow older, okay, now I'm going to be 68 very soon. When we were kids, my father used to work for the Reserve Bank, and people used to retire at 58. Oh, he's 58 years old. So I think age is very relative. Okay. Uh, See, the problem is that many times the so-called distress is more so in the caregiver when we have a conversation with the person who is a patient or who is suffering from it. Of course, they also will have their own problems. And the other very important thing, which I think which goes along with this, is the fear that if you tell the truth or if you break the news, because there's a lot of collusion that takes place. For example, in our hospice, 25% of patients who get admitted to a hospice don't know about their diagnosis or the state of their illness. So the fear is that if I tell the person what it is, they will lose hope. And I believe that hope is something which is not static; it is dynamic. Obviously, when you fall sick, the first hope that comes to your mind is that you will get cured. But over a period of time, when you move through the trajectory of the illness, the hope changes. And perhaps at the very end, everybody hopes to have a peaceful end. So I think it is very, very important to start that conversation and to give the person appropriate hope. And if somebody were to ask, I remember many, many years ago, I heard a very, very well-known palliative care physician from the US, and I was very new to palliative care. And somebody asked her that if a child were to ask you, "Will I get cured?" What would you say? And she, said, it's very difficult, but I would say, I'm sorry, I cannot take away your disease, but I can take away your pain. And I felt so pissed off with that statement. I said, how can you be so damn inhuman? And he actually left the room and went out. It was in a 5-star hotel near the pool outside. And now over many years, I realized that it is, if you actually engage in that conversation, it's not so difficult. It's just the starting. And we have, my counselors can tell you that they have talked to people who are dying, who are young. Okay, they of course have a disappointment. And part of that disappointment is not so much the fact that they are not going to live long for their own selfish interest, but there's a sense of guilt that I, as a son, am not able to perform my duties to my parents to look after them, and this is what it is. So it is complex. Certainly, people who are very old would probably uh, be able to accept death much easier, no doubt about it. But unfortunately, now finally is that because of the fact that there's such a lot of technology that is available, and you can cheat death for a long time. At some point of time, you have to give death a chance.
That's true. That's true. I'm reminded of that TED talk by, I'm forgetting the name of the lady. I think it's Emily. And she speaks about how she's waiting to die because, she would like to transition. But it's a hard one given what are the other messages that we are continuously given as society and we continuously believe in. Oh, with that, I'd like to ask Naina. See, one of the things that Dr. Nagesh spoke about is hope. And I think that closely linked with that is sometimes how family caregivers, in their desire to be protective for their loved one, sometimes don't even share the prognosis with the patient themselves. Although the patient has a very clear idea that things are going wherever they are going, they have a sense it's their body, but the family members feel, I've heard this so many times, I don't want my mother, daughter, whatever, to give up their will for living. Because if it's a mind over matter game, and if they gave up their will, maybe it will be even worse. What would you say, Naina, to that?
Uh, we receive so many patients here, and either they know they know only diagnosis but not the prognosis part, or sometimes they'll even come from a background where they do not understand the diagnosis itself. So when it comes to that, actually family will be very much close to them and they'll be overwhelmed with whatever is happening, and they think that patients will also feel the same. But I could give an example here. One of my patient's daughter, she is the only daughter to her parents, and the mother died of cancer in the month of December. I remember it was this month of December when she admitted her mother, and the same time even her father got diagnosed with cancer. So she decided to keep it from both of them about their own illnesses and also about their spouses, because she thought she's protecting both of them. If they both get to know that they both are about to suffer a lot and pass on, and they'll also worry about her. She's still unmarried. She's 32 something. So she is still unmarried, and her career wise also she is not that settled. Financial problems are there. So they'll worry about her future, and also both parents being diagnosed with cancer, there are high chances of her getting cancer in the future. They might think and they might worry. All this was her worry, not to tell about the diagnosis and prognosis part. But her mother, she was also not interested to know. She was the one who admitted first here, and she was like, whatever my daughter decides is fine with me. I really don't want to know anything. And she suffered a little because she was like totally trusted the daughter, and that story ended really fast and easy. But when it came to the father, it was a totally different side of the thing. because now he is grieving his wife's death, and also now he doesn't know what he is going through. And being when his wife is no more, at least when the wife was dying, she thought the husband will take care of the daughter because she didn't know about his prognosis. But when he is dying, he is more worried what will happen to the daughter in future. And every day I pass by his bed, he'll be waiting eagerly for me. He'll call and ask me what actually is happening. I told him, like, okay, I'll talk to the doctor. I'll make your daughter come to you and speak about it. And I started the conversation very lightly, like, how much do you know about the illness? What doctors already shared? And what are you expecting? The protocol, whatever the spikes is there, I started using it. And then next time when I speak to him, he started asking me doubts like, is it TB? Is it cancer? Is it that? Is it this? Overnights he'll be thinking about it and he will be sleepless. And in the morning he'll be waiting for some answers. But the doctor was like absolutely not ready to let us even talk to the patient about the prognosis. And when I started explaining her, see, this is the last chance you're giving for him to express his last wishes if he has anything. He wanted to guide your life, stay for you forever, to guide through your life. And you're taking out that opportunity from him. So she finally agreed to sit with me and go ahead with the diagnosis, breaking the bad news part. And when I just told him, I didn't explain anything. I just told him, you asked a question, and it is one of those two things you were thinking. Then he was so relieved, like on his face, it was visible. And immediately he was angry with the daughter. Like, why did you keep this from me? She started explaining, like, see, you're suffering, your wife just died. How could I come and tell you? You want me to inflict hurt on you? All these things she started telling. Then he gave one statement: it's my body. I need to know about it. And I will make the decisions for myself. And that statement was like really the end thing for him. And then when we clearly explained what was the process, what was happening with all these things, and what she must be going through, he understood. It took time. It didn't happen overnight. It took time for him to understand his daughter's perspective too. And then until that point, until the breaking of bad news, he was more like, when I'll have at least 2-3 months time, I'll search for a guy and get this girl married before I die. But once he got to know he doesn't have that much time, his perspectives has changed. He thought how to make financially independent this girl, whoever she's going to marry or not marry in future, but at least she need to be financially independent. And he being a businessman for so long, know how to make her become more independent. And it gave both of them a chance to really help each other to move on. And this is where it shows that BBN, breaking bad news, is very important in settings like this.
It is. It is. So thank you very much for that. Dr. Raj, I have a question for you that came up as Naina was speaking, which is that you come across as this doctor, and I'm sure your patients are quite blessed to have someone like you who has this experience and this perspective. Unfortunately, there are a very wide range of medical practitioners who may not have that perspective or that education or that skill. How what can caregivers who may have other doctors or physicians that they are interacting with do, or what can their well-wishers do? So, one of the things that we believe very strongly is, while there is the primary caregiver, they also need a gentle nudge from the other family members around them, right? And sometimes the well-wishers don't know what to do. So what would be your advice for those who may not have access to doctors like yourself? And what is it that the well-wishers can do? Please unmute yourself.
Ah, so, by and large, I take the perspective that my primary responsibility is lies with the patient,
Yeah.
not with the family, because that is the context. That's my primary duty. Duty of care is with the patient. So, duty of care involves respecting autonomy.
Mm.
Respecting autonomy means truth telling, telling the truth, and the whole truth, complete truth. So, when I'm able to communicate with the patient directly, sometimes they are unconscious or they don't have capacity, then I do gently talk to the patient, elicit questions. I don't just go and say your prognosis is bad. I just try and find out what the patient knows already, okay, and what the patient wants to know, because patients generally have the instinct. They want to ask me, can this disease be cured? They ask me. Or they ask me, how long do I have, doctor? Or do you think this will go away or it's going to get worse? So these are the clues. They don't ask you a direct question. Sometimes there are clues from the patient which you must pick up and then open up the conversation.
Mm.
If the family member, sometimes they tell you they have reservations, doctor, don't tell him, just as your patient, Naina. Don't tell him he will suffer or he will have a more speedy end, where this is unthinkable. Then you must spend time with the family caregiver because they need counseling. It doesn't mean that you override them. It means that it's a call for help for them as well. That they have a problem in accepting a fact. There is a denial issue going on there, and there's a conflict going on there. So you take it as a conflict which needs to be resolved first up. So you sit them down and tell them, look, contrary to what you think, opening up a conversation, telling the truth actually will relieve him or her of anxiety and the feeling that he or she can't trust anybody because they're not telling the truth. So, to build a trust at two levels, one is the physician patient trust. It doesn't come just like that, it's sort of given. It comes by building it up. Same way, physician family trust. So the bridges have to be built by telling the truth and staying with the truth. It may be hard going initially, but once you build this foundation, rest comes easily. So I have spent time with the family, telling them why it is important to tell the truth. That particular day, they may go away not so satisfied with what you're saying. Next day, they are a little more open. And on the third day, they say, one may come back and say, he's asking me for an answer. What do I tell him, doctor? You please help me. You break the news. By and large, the family tells me to break the news. That I've seen consistently. You do it your way. I said, I'll do it. Don't worry, we can do it. You can either be present there, or if you don't want, you can not be there, but I will break. First thing is to sit by the patient. Sitting is important. Not taking around and standing, you say something not right. Pull up a chair, sit down. Make the patient believe that there's all the time in the world. The time, whole world will stop moving until you finish this conversation. When you have time, when you have the intent, you have the presence. These three things. The physician must be present for that question. And so the senior doctor must take charge, not the junior going and telling him. Or if there's a junior, then should be properly trained. Sit down, ask what he knows, he or she knows. What do you know? What do you think? You have any question? Is there anything you want? Is there something you want to say? Okay. Is better than saying, is there anything you want to ask? Okay.
Mm.
It's an open-ended one, but also open to any direct penetrating question. Is there something on your mind that you want to ask? There usually is. Patient says, doctor, I don't understand what is going on. So every day you come and write a different medicine. Every day you're writing a test. Where is it all heading? Okay. They have an instinct about it. And I say, yes, you have a problem. You have a condition. Is it serious, doctor? That's the next natural question. Is it serious, doctor? So you pick up the clues. You don't say, no, it's very serious, very grave. You don't say that. Say, do you want to know more about it? Nagesh has taught me all this. Nagesh is a big communicator. So he has taught me what are the phrases to use. So I've also, through getting battered, I've also learned a few things to use. Phrases to use are, is there something you want to ask me? Or is there something on your mind? Do you want to know a little more about it? Okay. He says, I feel terrible, doctor. I feel anxious. No, don't worry. That's not the response. Don't worry. There's nothing to be anxious. No. See, you want to talk about it, right? So this is the way you want to talk about it. Break the ice. Engage. The key word I want to say to all of us who want to be caregivers is, it is a tough conversation. It is a hard conversation. It's hard not just to the patient and the family caregiver, hard for you. So unless you tell yourself, okay, before the conversation, look, it's going to be hard, but please stay. Don't run away. Don't go into a denial mode. Don't go into a flight mode. Stick there and go through this because this is very crucial. If you build this bridge today, tomorrow will be easier. Because you have to enlist their cooperation to take a decision, a medical decision. Medical decision isn't arithmetic. You have a prognosis, you have what works and what doesn't work in your head. But how do you translate that into a decision unless these people cooperate with you? So even from a purely medical point of view, you have to engage, get the trust, break the news, good or bad, properly, completely. It's a duty of care. It is not an optional thing. It's obligatory to tell the patient. I would, even if the family says, don't tell him, I say, sorry, I'm duty bound to tell him, but I will tell him my way. And I will tell you why we must tell. What is your problem? Why don't you want to tell? This is what I ask them. Why don't you want to tell? You think he'll get more anxious? I'm sorry, he's going to get even more anxious if he believes that we are hiding something. It is something which you cannot hide forever. It's going to open up very shortly. And where will you go? He will lose trust in you, he will lose trust in me. This is what I tell them. Okay? A relationship breaks if the trust breaks. So please, this is the time when your relationship has to be strongest. You have to believe in each other, trust each other, so don't hide anything. It's the way you say, it's the way you put it. And then so many decisions are hanging in the balance. And I cannot take a decision unilaterally by oath and promise, okay, of care. Okay, Bhavna. And what do you think, Naina? Do you get these problems with you? You've given an example. I face them every day.
If, Bhavna, with your permission, before Naina comes in, I think if I understood the question that you actually started asking, Raj, was that if the patient / family members were not lucky enough to get outstanding communicators like me and Raj and Naina, what should the caregivers do? This has been a dilemma that a lot of people have asked me.
Yes.
And in today's scenario, okay, first of all, most doctors don't know how to communicate, by far and large. The second thing is that when the relative or the attender or whatever sits in front of the doctor, we tend to get overwhelmed. I think in a very gentle way, if I were to advise somebody, oh, my doctor is not telling, you could say that you are welcome to challenge him very politely and say, excuse me, doctor, but, I would like to know this, or I do not want to do that. And, I would say you don't have to be rude to the doctor, okay, but you can stand firm. And if the doctor just does not and starts talking nonsense, and you're most welcome to say that I do not appreciate this, because you theoretically can complain about such a person. In fact, tomorrow, if the doctor does not give me pain relief, I can sue him. The situation, because I'm not talking about this thing. And finally, what I also wanted to say was what Raj was talking about, in the sense, please don't tell, is what we call as collusion in our communication skills lingo. And obviously, in almost all instances, the caregiver who says do not tell is himself or herself going through a major dilemma. They're totally confused, and they feel that they want to protect the patient, and there is the deep-seated fear is there. So I think there is, of course, a way of handling this collusion, where you'd say, I appreciate, what a wonderful, you can even lie and say, in my 30 years of practice, I haven't seen a more compassionate brother than you. My God, how much you care for your sister. But you realize that, and allow them to to factor that idea, because you do not want to have a confrontational relationship with the caregivers as a doctor, because you need their help for the care of the patient. But if things become impossible, and then as Raj said, your duty is towards the patient, okay, and you could do that. I think Naina would probably give a wonderful perspective, because I'm the general sitting in my air-conditioned room. These are the soldiers who are actually fighting the battle, which I did years ago. But if it's okay, you could ask Naina to respond.
Yes, absolutely. Yes, Naina.
Yeah. Here, the reason for worry is different for each caregiver. It is, some people feel that they might take it offensively. What are you eyeing for my property? Why are you starting this conversation? That might be a reaction from the patient, the caregiver will be expecting to have.
Yes.
Or some people might be like, who are you actually? If it is not like a very close relative, but a very concerned person. Like if I need to go and talk to my in-laws about their future plans of treatment, they would certainly think like, why is she asking about our death? I mean, where is it coming from? So every caregiver's worry is different. So as a caregiver, you could do is what you explore more into your worry. What exactly is are you worried about?
Right.
And there will be a certain family member, not if not all is agreeable for the conversation, there will be one person who will be like, okay, this makes sense to me, and go to them and seek for support, ask them for the opinion, and it will help you understand yourself and the patient and the support you need to get, when you could get the support, from where you could get the support. And if the professionals like sirs are available, then you could always seek support from them also. You need to explore more into the options, you need to know it before you start a conversation properly. So what are the really options available for us now, and who and all are supportive enough, and whom does the patient would prefer to have this conversation from? All this research need to happen even before you start a conversation with the patient. And there are, if you are not able, let's assume that if the patient is not terminally ill, it's just your elderly parent or an in-law or a friend, family friend, and you want to start it, you could observe and identify subtle changes in their behavior or health. Like for example, one of my colleague was saying, my daughter came to me and she told me that your snoring is different from before. Your snoring is different, mom, so I think you might be having some kind of breathing difficulty. And see, and she started with the hope again. It's not like the hope is dynamic, as sir was saying. She didn't say that everything is fine, nothing is wrong. She just started like, I want to be with you through this. I want to see you having deal with these things. And I want to support you throughout the treatment, whatever it is. So this reassurance that I'll be available, I really concerned about you, and it bothers us. And this is how, when you identify these minor things and let them also focus on their health, let them also come to a same place where you are to seek the help of a doctor, or just go and think about what they're really going through. So the preparing part will also become a major thing here. And when you are thinking of having conversation, you are thinking and you already seek support and everything, and have a practice conversation before going to the patient. That will make you feel confident. It's just like a rehearsal. You just need to sit through it. It is painful. It is as overwhelming as it is happening right now, but it is important. That is what you will be prepared for when you're actually talking to the patient. This is like just getting ready. Then you need to set up other things. Then you could move forward in this process.
So, in addition to probably talking to a counselor like yourself, or perhaps having a doctor, someone like me will want to perhaps prepare herself very well. So, like I'm not the kind of person who will say, I will just go with the expert. Tell me what's going to happen. So, is there some kind of a process or a checklist or something that one could use, because this is not my line of work. My line of work is different, but now I'm in this situation, so I have to prepare myself. So how can a caregiver prepare themselves for this crucial yet difficult conversation?
Okay, I put myself in the shoes of a caregiver, right?
Yes.
Now, how I can prepare myself? Say, firstly, I must ask certain fundamental questions about the human condition. You see, what is my attitude towards death? Okay, that defines the whole thing. As you mentioned, in order to live well, you must know what death is. And why? Because, to get a perspective of life, you have to have an integrated view. And then if you leave out death, which is the one absolute reality and will affect all of us, then we leave out a whole area of knowledge and perspective. So if you have to be a caregiver yourself, you see that one of your parents or somebody elderly is there at home, you have to ask yourself, what is my attitude towards death? Because majority of us, either they have not asked that question, never asked what death is. I mean, you always feel it happens to somebody else, but you ask one logical question, will it ever happen to me? You have to say yes, isn't it? So, because it will affect everybody. Death and dying experience has to be receive some attention before we can humanize ourselves enough to take care of another human being. Because that unifies the human experience. So the inevitability of the death when you can see, and then will come emerge what is the purpose and meaning of life. It is not being alive. That alone does not define life or provide meaning. The meaning is how you understand it in any situation. Your condition, human condition, how you understand it, what meaning you've infused into it. Some people understand, when you understand death and living, you understand that the means are as important as the end. Okay, because the end is inevitable. But then what is life? Life is not a mere passage between birth and death. It is a meaning. You read a meaning through your passage. So when you can read a meaning into the human experience, then you know what caregiving is. Okay.
Yes.
Caregiving is reading a meaning.
Nice.
It is not a chore. It is not a work. It is not a labor. It is not something you have to get through. Okay, go through the motions. Caring is a way of life. It's a way of looking at things. So I think if you ask the fundamental questions about life and then you read a meaning into what caring is, and you When you read a meaning, it gives beauty to your existence. It gives you purpose. It gives you. It makes you grow. You can feel yourself growing when you actually care for you know when you're involved in terminal care. I have seen a number of children who are born handicapped or okay, um, Down syndrome and all that. The parents sometimes glow out of a selfless caring, knowing there's no tomorrow, I mean, a proper future, but they grow as people. And look, people like Naina start to glow after some time because they read a meaning in everyday work, right? Nagesh, huh? He's a very jovial guy. Why? Because it's not about what you're confronted with. Day in, day out, he is looking at cancer patients and their last legs, and half of them die. Yet he's an extremely jovial person.
Yes.
This is what I mean. I see death every day in the ICU, right? I see only people with complaint. I never get to see people who speak normally. They have only complaint. But after some time, you start to understand that look, the perspective is everything. As a caregiver, you must improve your perspective. Okay, as an ordinary caregiver or as a professional caregiver. You must not shy away from basic questions of life. Then you will not shy away from the bedside and sort of looking at death, opening the conversation about death, and all the turmoils that go through when you have a conversation.
I think he's frozen.
I think he's.
Bhavana, I have posted a link on the chat box, the conversation project, which Roop Gursani had suggested that I also go through. And there are a lot of other resources that are there in order to give some sort of guidance to the caregivers. It's not easy.
Right.
And I think the more we talk about it, and now, with the concept of an advanced will and how do you get a conversation going, it will take some time. And there's an enormous amount of resistance that is there. But we just chip away as much as we can. I think the participants may want to ask questions because I noticed that we're already 12 minutes past 5.
Yes. So I'm glad you brought that up. This is exactly what I would have done. Ask the audience if you have any questions. Would you like to raise hands, or would you like to leave a question in the chat box? And as we wait for the questions and I look out for people who may have raised their hands, I don't know, I have so many examples in my family, so I'm just thinking about them. My grandmother used to have this, elaborate thing about how she wanted to die, because there is a certain ritual and there is a certain thing, a value to transiting from this life and to the other. So there is a question, I will take that question first, where the more details about the advanced will are also available on the Caregiver Sathi website, and we will certainly put them up for participants and we will share. In fact, there are a couple of other resources as well as a part of the End of Life team that have put together awareness and so we will share those resources, and they're available on our website that people can access to be able to write their advanced wills. Now, coming back to my experience, we used to find it really funny at some level and morbid at another, that my grandmother wanted to make sure that everybody was trained when she would die. So, that whole thing of Tulsi, Ganga Jal, make sure I'm on the floor, breathing like this and that, etc. And we used to We used to be horrified how she would want us to know all these details. But to cut a very long story short, she willed how she wanted to transition, and she made sure that people were trained about it. And frankly, that's how she transitioned. A huge lesson. Sometimes there is a lot of solace in our rituals, and each faith will have their own practice. There is a question, Dr. Nagesh, about younger patients. You know, when there is a member that has suffered a stroke, and young family member, it's very hard to communicate with the rest of the family when there's a situation like that, or end of life for a young person. What would you advise in such cases?
Yeah, I read that on the chat box. In fact, the question came earlier, and uh, Chaudhary has repeated that. Uh, Obviously, if it's a young person who's had a stroke and is aphasic, is not able to communicate, it is extremely difficult. So now, one of the ways which what neurologists would do is obviously, use sign language. Uh, but if it is somebody who you're anticipating is going to, to have this sort of a problem, then it's the time when we talk about the advanced will or the advanced directive and what are those values that the person has. Now, if it's just a stroke, the person is not able to communicate, but that person is not dying, imminently dying. Obviously, you continue with the treatment. You hope that the person is not who's not able to speak. That is a temporary thing, and it reverses. So the only way to do that is to use some sort of a sign language. And if the question comes about what would be important for that person, if the person has obviously not put it down, then one has to consult with the family members. Now, here comes the problem that the family members, all of them don't see eye to eye. Each one is perspective is based on what they think is the right thing, and there's also a sense of guilt that if I were to do something which is irreversible, I should not blame myself later on. So it's obviously not easy, particularly for young people, and it's even more difficult for the family members to see a young person suffering.
Yeah.
So there's no simple way of doing it. You just got to to try and communicate in some sort of a thing, but it is difficult, no doubt about it.
Yeah, yeah. I think it's one of those situations where, it's the expression being that you catch the bull by the horn.
Uh, in our situation, we went through this some years ago, but she had had a pontine brain hemorrhage and she was not going to get well, which is what they had told us, that even if she lived, she would be a vegetable.
Right.
But we faced a lot of resistance from the doctors they refused to let us take her home. Even after she had been in the ICU for 40 or 45 days. And they would say things like, today she blinked, today she coughed. And so, why do you want to take her home? And it was extremely difficult for us, doctor, at that time to
Yes.
know whom to turn to, because the doctors wouldn't, or the hospital were not willing to release her. What does one do if they are faced with such a situation?
Yes. Now I think Dr. Mani has come back. He had dropped off in between. Raj,
No, the Wi-Fi had failed me.
no, whatever. I think. Did you hear the question about?
Just now I could catch something now. I think somebody was in a vegetative state, and
That's right.
the doctor wouldn't open it up and let them go.
Yes.
Now,
You're the best to answer that.
When that happens, which happens very frequently, you have to ask the doctor, Doctor, I want to have some time with you to openly discuss and frankly discuss the condition.
Yes.
Sometimes what happens is the doctor assumes that you don't want to know the truth, and you are assuming that doctor doesn't want to tell the truth, right? So somebody has to do the pahel, okay? Either the doctor calls you, sits you down and say, see, let's have a frank conversation. If the doctor has as much hesitancy as you have, then you must take the initiative and ask me, doctor, I want to know the truth from you, okay? Let's have a frank conversation. It does help. So if either one is open for a conversation, then an open conversation will take place. Many times there are fear complexes in the doctor caregiver as well. They think, the family is suspicious of me. If I tell them that the prognosis is poor, they'll suspect my competence, all right? Or they might complain against me or file a suit. Okay, these are fear complexes. And the family always is suspicious, says they only want to make money. They will not tell me the truth because they just, meter is running. So why would they tell the truth and ask me to go home? So while some of us do deliberately, not open up, but the majority of us just need a little catalyst for opening up, a little trigger, a nudge. So this conversation, if you have, it'll save you from a lot of suffering and the patient from a lot of suffering. Unless you identify the patient's condition correctly, which phase of illness the patient is, whether it's in the curative phase of illness or a preventive phase of illness, then curative phase of illness, or in a phase of illness which is out of the curative ambit, it has come to the phase of illness when terminal care, comfort care, focus on dignity, focus on symptom control, um, you know, each stage needs specific skill, expertise, understanding. So if it's a conversation opening up means opening up the best available options for the patient. The best available options are to jettison the aggressive options. That itself unburdens the patient and the family, not just in financial terms, actually in physical terms.
Thank you
Raj,
so much.
Raj,
Thank you, Dr.
if I might just come in for a second, I think what she's also mentioned is the fact that many times, with this confusion about the law, and they're worried that the family will take them to court, and the current law does not allow. That confusion also is there in the background. So
Yes,
I
because
think
we had this conversation with the doctor. It was very clear that she was not, she would live only in a vegetative state if she lived,
correct.
but
No,
they
no, but
yet refused to discharge her.
that is because of the fact that if you look at it very strictly by the law at the moment, okay, it's a very cumbersome process. So the End of Life Care Task Force, of which Dr. Mani is the chairman and I'm one of the founding members, we have been working on this. Supreme Court, constitutional bench has been approached. COVID has come in the way. So we
Right.
hope that in maybe 6 months, 1 year's
No,
time,
let me
there will be
clarify.
clarity.
With Nagesh and on behalf of Elicit, which is a group, advocacy group, let me make it very clear: there is nothing in law against common sense. All right. So to use law as a alibi not to do the right thing is just not on. Nobody can stop you from taking the patient home. Which law can stop you? Is it stopping anybody? When no law is objecting to having an open conversation, firstly, all law will tell you to tell the truth to the patient. No law can tell you to burden the patient with care he will not benefit from. So forget about legislation and other thing. Let's use common sense. We have survived on common sense only. Every day we are taking these decisions.
So, Dr.
When there is
Raj,
a
I think
vegetative state, when there's a vegetative state, you can take a patient home. After adequate conversation and how to manage the patient at home, you can take the patient home.
Dr. Raj, I think sometimes the caregiver has the dilemma or the tension that how do I contend with the hospital or the doctor who's advising against this? Is there a body or a set of people that one can go to for an alternate advice? So if I were to put myself in Zavir's shoes, I would think that I should be aware that I have this doctor and this hospital who is advising me this. They are telling me that there is perhaps, ICU, vegetative state, etc., etc. But they're also not releasing. They are saying that, we are not going to take responsibility. What's a recourse for a family member?
I
Can
think
they
resource,
go?
that's a very valid question, Bhavna. And the thing is, now, Dr. Nagesh and I, when we were respective presidents of our societies, Indian Society of Critical Care Medicine and Indian Association of Palliative Care, we formulated a joint guidelines.
Yeah.
For the care of the dying, it's called, okay?
Yes.
Um, uh, ISCCM, IAPC guidelines on end of life care. That is a very valid resource, very exhaustively prepared. That's all available on the net. So, a body of physicians from two specialities have sat and made a guideline on a panel which also has a legal advice. And subsequent to that, constitutionally, it's been declared valid to have withdrawal and withholding decisions by the common cause judgment of 2018, which Nagesh was alluding to. There are certain problems with procedure there, which we are addressing, but in principle, in concept, and in constitutionally, we it's totally valid and legal and decriminalized to do a withholding and withdrawal decision. Having said that, there is nothing in law to stop you from taking the patient home, discharging and taking the patient. There is nothing in law, as far as I know. We have been into law for so long. Now we are working with Vidhi Center for Legal Policy, which is a very specialized legal cell which advises the government on various matters. Now, that has made a model draft bill that is also very clearly validating withdrawal withholding and having a procedure which is reasonable within the hospital. You don't have to go to court or any district, counselor or anybody. Why? Because the principles are being followed. What did the law say in common cause judgment is, please don't take a unilateral decision. Take a decision with the family in confidence. Don't take a single person decision. Have a collegiate decision. Have a few physicians, three physicians, family. They take a deliberate, they say cogitate and then take. So take a deliberate decision and have a proper documentation which reveals your transparency and honesty of intent. So if you do that, then you are safe. So in medicine in general, even if you take a non-end of life decision, you take some medical decision, you are supposed to document, and that shows your intent, that reveals your honesty. And then all medical decisions, whether you put a patient on treatment or withdraw a patient on treatment, has to be according to a standard. Okay? And that standard is provided by professional consensus document, which is ISCCM IAPC. Wherever you have an ethical dilemma, you don't want to confront it, you run away, okay? Then you blame it on the law. That isn't fair, okay? You take an ethical decision and you got a full methodology available.
Yeah, I think sometimes, it's a case of adequate awareness among the caregiver families, because we don't indulge in preparing for, illness. We don't indulge in preparing for medical emergencies because, we'll cross the bridge when we come to it. Right. So I think sometimes families and caregivers need guidance, and they should be able to go to somebody other than the main doctor. And the way that I hear you, I think sometimes we are not the primary caregivers. We are the well-wishers. We are in the outer circle, so to speak. But we can have knowledge and we can find the alternatives. So my request would be that you may not be a primary caregiver today, but there is nothing that prevents you from being supportive to the family, the caregivers, and somebody else by simply accessing these alternate sources of information. I see Naina is nodding very vigorously. What would you have to say to that, Naina?
Information is everything.
Mm.
If you, I find like so many patients, caregivers come to me and say that, see, this person, my father was suffering for a month, and overnight he was not sleeping at all, he was not eating at all, and today he is sleeping, first day of the admission, after some medical procedure, he is sleeping. And I feel so peaceful. I feel so relieved. And 1 month of suffering every day, every night, every minute of it would have happened if they just knew there is a place where they could go. There is palliative care, there is Karunashra, there is this place. So that knowledge is everything, that information is everything. It is not for you, not for today. It will be helpful for somebody at some time. And knowing is everything.
Yes, knowing is everything.
Yes.
And measuring is also very important in order to improve.
Yes.
Yes. So I'm going to really ask once again if there are any other questions that people in our audience participant group today have on the kind of roles that we can play. So sometimes we are primary caregivers. At that time, we are totally consumed. But there are many times we are, related to the caregiver. We are a distant caregiver, or we are, a well-wisher of a caregiver. And I think there are so many things that we can do in those roles as well. And I often feel that it takes a village not just to raise a child, but it takes a village to help people transition from this world to the other world as well. And I think it is tough, but it is possible. To the opening remarks that were made about, there is dignity in transiting and meeting death, giving death a chance, to use some of the phrases that were used here. With that, I will ask each of the panel members to give their closing remarks so that we can bring this webinar to a close. I'll start with you, Naina.
This was very informative. Actually, the questions which were asked were like really difficult to answer. Even for a counselor to just to start thinking of how to go around this. But an expert, there will be an expert for everything. Our doctors actually were very knowledgeable, and so many things I learned from today's this time. It's not, you need to ask a right question sometimes to the right person, and you'll definitely find an answer. So answers are out there. You just need to ask for it.
Thank you. Dr. Raj?
See, it's very heartening to see that there is a whole new venture looking at caregiving in general, and specifically looking at the interests of the caregiver, the usual caregiver. So it is for me a breakthrough, because evolving through professional caregiving, through caring for the dying, I understand that without the help of the ordinary caregiver, participation, engagement of the ordinary caregiver, it cannot come to fruition at all. And there's a whole area of suffering which we have ignored. It's an area of darkness. We have not looked at it. We have missed the chances of helping so many people in a meaningful way, and spare them from depression, anxiety, and post-traumatic stress disorder, which may affect them for their entire lives, to improve their experience, because dying is also an experience, a meaningful experience, an enriching experience, actually speaking, for the caregiver, for the ordinary and the professional caregiver. And for the dying patient, it can be a spiritual experience. It should be, actually. Nagesh will tell you, who is a pioneer in this area. So it's a spiritual experience which should be mentioned as well. So a spiritually meaningful, not necessarily you have mantras and other things around the patient, but whatever the patient likes, okay? Because the existential spiritual dimension we ignore only at our own peril of our own mental health, I'm telling you. So in the setting of the hospital, in the dying experience, all this human thing must come together. This will go a long way in humanizing medicine itself, improving our awareness, because caregiving is a calling. It's not a vocation. So unless we take it as a calling, as a means to improving ourselves, it will not be enriching for us. And I intend to make it more and more enriching.
Thank you. Those were such
Yeah,
inspiring words.
yeah.
Um, before you get to the closing remarks, Dr. Nagesh, I think I missed a question from one of the participants, which is, what if the patient is not willing to have the conversation? And would then the caregiver insist? Or what should the caregiver then do?
I think it's very clear that you cannot force the conversation on anybody, particularly if the patient does not want to have the conversation.
Right.
There's no question about that. But I think there is a way of reacting to that person, uh, gently probing what is the reason why the person doesn't want to. But at the end of the day, if the person just does not want to open up, then there is no we have no business to force ourselves. But if you talk to a lot of people, talk to my counseling team, this may be the initial part of it, but at some point of time or the other, that resistance generally breaks down. So that should not be a problem at all. So that's number one. As far as closing remarks is concerned, I think between Naina and Raj, they have, I think spoken whatever needs to be spoken. And I'm very happy, of course, with whatever Caregiver Sathi is doing. I think we have discussed this before offline that I think you need to scale up. There are a lot of other things that you can do. And you have, for example, Dr. Mani wields an enormous amount of influence in his area, in pulmonology. So I think we should have an offline discussion. And finally, I am delighted that all the things that I taught Dr. Rajkumar Mani, he has learned it very well. And he has proved that I'm an awesome teacher.
Yes.
Anyway, jokes
So
apart.
whatever mistakes I made also go to you, my friend.
Absolutely. I accept it. Thank you,
We are
Bob.
delighted. No, we are absolutely delighted and blessed to have the such nice words and so much encouragement from people like you, because as you can see, we are taking our baby steps in trying to build and scale our organization. We do think that shining the light on the family caregiver is an absolute necessity. As we speak today, there are 19 crore people in India that are suffering from a variety of incurable conditions, from oncology to neurology to aging to mental health conditions to congenital life-limiting conditions. So if there are 19 crore people affected, there are at least 19 crore caregivers, primary caregivers, maybe more. A rough estimate says that at least there are 1.5 caregivers to each person. So we are talking about a large problem that we need to address. And there tend to be women who are caregivers more than men, though of course now, the dynamics are changing. But when there are women who are caregivers, they're also bound by sociocultural norms of self-sacrifice, putting family first, giving up on their dreams and so on and so forth, which makes the caregiving challenge a lot more complex. So we need the push and the support that people like you are giving us. And I will definitely take you up on your offline conversation. Thank you so much for that. I was reminded of my uncle's poem, which I would like to end this with. It's a long poem, and it's actually a poem of valor. It was a call to young people in the 1971 war, actually. But there was a last line that I'm going to say. And in the last line, he says, जिसे मरना नहीं आता वो जिंदा रह नहीं सकता. Basically, if you don't know how to die, then you cannot live well. So I think it was just appropriate for today. And I'm very grateful for each one of you who have joined us. Thank you. Thank you so much.
Okay. Bye-bye, all of you.
The opportunity.
Thank you very much.
Thank you. Thank you very much.
Request the participants to please fill the form I have left in the chat box. Thank you to our wonderful panelists. Have a great weekend, everybody.